Welcome to the Surgical Edge. This week's podcast is going to be focused on the world of anesthesia and anesthesia subsidies with the subject matter expert that we are really excited to bring along with us. Quick introduction. My name is Stephen Spake. I'm a senior consultant at Sullivan Healthcare Consulting. I have a background as a surgical technologist, a decade as a combat medic in the Army, a little bit of higher education under my belt, and a few years in the consulting realm now. I've been proudly with Sullivan for about 2 years, and it's been a phenomenal experience for me, so I'm excited to bring everyone along the ride. I will let our guest introduce himself, but this is a Mr. Tim Hanners, a senior vice president at Sullivan. Tim, can you give me a little bit about your background? Welcome to the show, man.
Thank you. I'm glad to be number 3 on the show. I missed the first 2 slots, but I'm here now.
You did. You
But
did.
thank you. Yeah,
You're the
my background has been in hospital administration. Worked for mostly multi-hospital systems, both for-profit, not-for-profit, academic, children's hospitals, etc. So really ran the gamut of my career. But all of my career was largely involved with the physicians and providers. So a lot of provider recruitment, retention, referral development, even some back in the day when we were doing practice acquisition. So, a lot of focus on that. So it enabled me to really learn what's important to physicians, surgeons, all the providers, and sort of how they work. And then, trying always to help translate that to the C-suite of the hospital. So I've largely been an interpreter for most of my career. And I joined Sullivan only about 2 months ago, but joined because Sullivan is truly a top caliber hospital healthcare consulting firm. 40 years in the business, in the making, and really enjoy all the people that I get to work with now.
We're glad you're on board, man. It's nice to have your enthusiasm. I think in the limited conversations we've had together, you bring a lot of enthusiasm to the table. And I said right from the get-go, it's nice not to be the only one ending sentences and exclamation points in emails. It makes me excited to see someone else pump.
Right.
Consulting is such a niche thing that it takes a special personality to get excited about it. So it's always nice to see someone bring that enthusiasm, because I'll go up to my wife after working a day and I'll be
Right.
like, look at this great room concurrency diagram that I helped build. Like, it shows so much information. And she's just like, buddy, I don't care. So it's always nice to be able to reach out to someone and say, man, look at this cool thing I built that can show me, the percentage of ASC cases I can decant. So it's nice to
Right.
have that enthusiasm on
Likewise,
board.
likewise. I put my wife to sleep the other night reading an anesthesia contract to her. Yeah, I get it.
Um, so if can you talk a little bit or expand about how you got into the healthcare space? Because correct me if I'm wrong, your background isn't necessarily clinical in practice, but you've been in the healthcare sphere for your entire career.
Yeah, truly. And yeah, zero clinical sense about me. Patients have always been safe because I don't get involved in any of the actual real care or any of the real work going on in hospitals and healthcare. But yeah, I got into it in a time in, let's see, I guess around 95, when in Texas, the private insurance HMOs were coming about and really pitting hospitals against one another. And they were going to use the primary care doctors as gatekeepers and funnel the patients to the hospital of their choosing, right? So I came in as just somebody who was really understanding business, but didn't really know anything about the hospitals, but could understand. And so I learned just sort of cutting my teeth on the HMO world and on provider relations and going to primary care doctors' offices and asking them what they and their patients needed from a hospital. And so built upon that. And then I also largely got into the physician relations because of the Stark laws when those came out about the same time, and said you couldn't try and give anything under the table to doctors anymore. That was going to be frowned upon. Actually, now illegal, no more remuneration, no more kickbacks. And the CEO decided then I needed to be the guy in charge of the medical office building, which was undercutting the leases. And so I went in not knowing what I was doing whatsoever to talk to, every physician that was in a 10-story office building, the orthopedic surgeons, to tell them that I was going to be raising their rent by about tenfold starting immediately. So that was, went real well. I got my first rear end chewing from an orthopedic surgeon in his office because I didn't understand and did I know how much money he brought to the hospital for these last 20 years. And he didn't care if it was illegal, that we just needed to figure it out. So that's kind of where I got started in there.
All
And
right.
I guess because I survived those things, they kept giving me more things to do with the doctors, and I found it to be a pretty amazing industry that doesn't make sense to anyone on the outside. and as you know, Stephen, you've been all over it. It's very different every day, every year, new challenges. There's never anything that's easy. So yeah, that's how did that for a bunch of years, 25, 30 years, and then now have been consulting and getting to work with you.
Yeah, it's a good crew, man. It's a real good crew at Sullivan. And I will point out that you're really our first, quote unquote businessman that we have on this show. So it's going to bring an interesting paradigm to it. We've had Randy and Jerry, but you're the first real, I would say, administrator. And I know sometimes that's used, punitively in healthcare, but I think we bring a good partnership because we have both good clinicians and intelligent administrators that understand how to properly put the patient and the patient's care and the practicality of what we're doing into play. And today's episode is going to be heavily focused on the business side of anesthesia, really, which is a broad topic. And in order to not make this, a Melville novel, we'll keep it concise and narrow it down a little bit. We want to talk specifically about subsidies and their role in the healthcare ecosystem, specifically within anesthesia. So if you could give a $2 explanation of what a subsidy is, specifically for anesthesia, and then I have some follow-on questions about subsidies in for-profit and nonprofit systems. I'll ask to elaborate a little bit about that, but please go ahead.
Sure. Yeah, the subsidy, the S word, that's out there now amongst hospital administrators and particularly CEOs and CFOs with anesthesia. And it's happening with some other specialties as well. We're just going to pick on anesthesia today because we're into peri-op stuff, right? So, but it's
Yep.
happening with radiology. It's been happening with the ER, emergency medicine, et cetera. But basically, subsidies because the private insurances are lowering their reimbursement rates for anesthesia. So to the anesthesia provider, they're getting less money all the time, and the insurance just looks to the hospital and says, well, that's a hospital-based physician. You should just make up for that. That's just sort of your cost of doing business. You're making a ton of money in the OR. You figure it out. So they just lower that reimbursement rate. So therefore, the hospital, of course, has to have anesthesia providers. You have to have the anesthesiologists, the CRNAs, the CAAs, whichever you're using. You can't do an OR without them. Then the surgeons know that one thing they have to have, not the one thing, but one of the most important things, they have to have anesthesia, and they want good anesthesia providers that are permanently based there, that they can count on, that learn how that surgeon works, how that OR functions, and they really help drive everything daily in the OR. So the big question is, why am I paying a subsidy, and why is it going up all the time? So that's the first part, is why are we paying it? The second part is, why is it going up? Well, the anesthesia providers are in short supply and high demand, and there's not more of them coming out as to meet the need. So they are simply put, demanding a higher salary. They're also demanding higher vacation time. They want more free time. They're tired of the burnout. They're tired of that long grind when the OR never seems to shut down, and they're called upon to be there no matter what. And in addition to all the other places that they're providing anesthesia now. So they're getting called into cath labs and IVR and, all kinds of different places that we're providing anesthesia, all the non-operating room anesthesia sites. It's all of those factors is why the subsidy is going up. And it is a reality. There is going to be a subsidy if you're a hospital for your anesthesia. The big trick is, can you keep it stable? Can you keep it somewhat predictable at least? And are there ways that you can have the anesthesiologist partner with you to actually help maintain their own subsidy? They still get their same pay, but you're not paying the high subsidy that usually is because of locum tenens or something like that.
Okay, thanks for that. That's all good info. And just for the sake of, clarity and scope, what is the normal subsidy value that we would say a 12 to 15 room hospital OR pays monthly or annually for their anesthesia providers, just so we know what we're talking in terms of scale?
Yeah, no, that's a great question. And I hate to give you the "it depends" answer, but as any good consultant would say,
Exactly.
it does depend. And so even the biggest factors that contribute to that answer, I mean, so we're talking millions of dollars, right? I mean,
Yeah.
it's, starting in the millions, and then you're going up to, multi-millions of dollars. But the biggest factors that are part of that formula is what's the blend of anesthesiologists to CRNAs, for example. What's the number of sites that you need covered? What's your call demand? Are you a level 2 trauma or even level 1 trauma? So what we do is what we try to get to is what's the right staffing model to meet the needs of that hospital or even the ASC. But what's that right staffing model so that you don't have providers, anesthesia providers, sitting on their hands? You're keeping your ORs running and you're providing the coverage that you need. The first question is, how many of the anesthesia providers do you actually need, and what's the blend of that? Then you can get to, well, what should that subsidy be? There's going to be a subsidy, but let's help figure out what it reasonably should be.
Yeah, that sounds like a good place to start. And as we're looking through, this subsidy, I'm a very visual person, so I see subsidy as a curve, and it's an increasing curve through time that, as time goes on, your subsidy increases. And I feel like the goal of what we provide and what most OR management would be interested in is really trying to find a way to flatten that curve out. And at least you're going to pay a subsidy, but what can we do to keep it from increasing significantly, whether it's linear or exponential, flattening that curve as much as possible. And you brought up the one of the first points of that, which is a practical and flexible staffing ratio. We're big fans of the anesthesia care team model, splitting that workload between MDs and CRNAs and really bringing efficiency to the table and affordability to the table that way. Can you provide a little bit of background as to how the anesthesia care team model helps reduce subsidy amounts at the end of the year?
Let's make sure I'm understanding your question, Steven,
Yeah.
real quick. So just that, how can the right size anesthesia team help you control your subsidy? Is that
I guess a better way to phrase it is the anesthesia care team model more cost effective for organizations in terms of subsidy? Are you going to pay a lower subsidy if you have a higher volume of CRNAs, or are you going to pay a lower subsidy if you have all MDs? Because there's so many hospitals that we work with or tangentially related to that say, oh, we want to run all MDs, and it's like, cool, that's going to be expensive. We
right?
get your desire to do so, and a lot of times, at least in my experience, that desire comes from the anesthesiologists in that facility saying, no, we don't want to work with CRNAs. We've seen that over and over. So in a
Right.
scenario where we're walking into a hospital that's saying, hey, we want to lower our anesthesia subsidy because it's costing us $15 million a year for 20 ORs. What do you think we should do? Generally, our first response would be something along the lines of employ an anesthesia care team model. What would you do to encourage an organization to look at that anesthesia care team model and maybe supplement some of those MDs with a more affordable CRNA?
You're absolutely right. And so that is key. You have to be not only using CRNAs, but use the CRNAs at the top of their license and allowing them to do the things that they are fully capable of doing, and they do not need an anesthesiologist always in the room. And so the goal is to modernize the anesthesiologists so that they are doing the things that really only they should be doing. And of course, you have certain procedures like, open hearts or
Open
hearts.
hearts. Yeah.
Sure, makes sense. But the CRNAs are perfectly capable of running, the pain blocks. They're capable of running those lines. They don't even need the anesthesiologist to get the patient started. They don't have to be in the room. So really maximizing the use of the CRNAs. And you're right, there still goes on this unfounded fear, if you will, that and sometimes it's even brought on by the surgeons, but that, well, quality will go down if you don't have enough anesthesiologists, if you're using too many CRNAs, or that it will become more efficient. And a lot of times, unfortunately, anesthesiologists perpetuate this, and this is the way it's always been done. We tend to just stick with that habit, right? But
Right.
the CRNAs, especially the ones that are coming out now, are 4-year programs. They're actually a doctorate. They're a doctor in CRNA now, and they are extremely and perfectly capable. My experience has been a CRNA will not try to do something that they are not confident in. They will not try to do something without the coverage. Nobody wants to do that. It's first do no harm for everyone. So CRNAs aren't out there like mavericks trying to say, oh, I can take on everything I'm not capable of. But that is absolutely the key. And then adjust your scheduling accordingly. Now, the other thing is too, Stephen, just a slight tangent on that is There's a lot of confusion out there, especially amongst the hospital administrators, but even amongst surgeons on the difference between medical direction and medical supervision. This is confusing, and they may even catch wind of the term QZ billing. Well, the main thing with medical direction and medical supervision, certainly QZ billing, is just that it's about the billing. It's how do you bill the insurance and how are they going to reimburse. So you don't have to just stick to one or the others. Medical direction might be 1 to 3, one anesthesiologist to 3 CRNAs, for example, versus a supervision model might be more like 1 to 5 or even 1 to 7, especially if it's an outpatient setting. The good thing is the CRNAs are less expensive. They demand a lower salary than the anesthesiologist. So you want to get to where you can maximize that ratio for your billing, but that doesn't mean that every day, even if you decide you can go 1 to 5 ratio, that of course doesn't mean that every day is going to be 1 to 5. It doesn't mean that all of your ORs are going to be spread out amongst a 1 to 5. You are still going to have days and ORs that might be a 1 to 2, right? And so they have to take that into account, but good anesthesiology leaders recognize that it can help that. But that's how you can help flatten that curve on the expense, at the end of the day, is you're simply having to pay out lower salaries. So does that help?
Yeah, absolutely. If you are walking into an environment that is like an MD only model, how do you start that conversation with that executive leadership team, be it COO, CNO, CMO, to say, all right, we've identified you have some challenges with your subsidy. The first, the biggest concern for that maybe from us is the fact that you're MD only. How do you instigate them to start the journey of let's talk care team model?
Right. So first I put on my flak jacket, right? Because I'm going to that kind of a meeting. But I will tell you, it's always important, and we always work in a dyad. So it's me, and it's sort of peer to peer. So it's me and an anesthesiologist as a dyad consultancy team. And that way it's a little bit more peer to peer. I'm talking with the administration, I'm talking with some of the leadership, and our anesthesiologist, he's talking with the anesthesia providers, because it's important that he'll be able to explain and talk through that we're not infringing on good quality. We're not making, slower efficiency or anything like that, because otherwise it might come across as just, I'm just another money grubbing administrator with this idea on cost cutting, right? So it's important that we're able to talk with the surgeons as well as the anesthesiologists and talk about and help them through this, because sometimes they just need help understanding how to make this happen. They haven't done this. Maybe they're older in their career. They weren't exposed to it, recently in their medical school or training. So it's a lot of that, of helping them just understand that this is still even though it's modern, is still a very safe environment to operate in.
Yeah, great points, and those are some challenging conversations to have. We're starting them right now with one of my clients, so I feel the pinch on that one, and I'm really happy that we have an anesthesiologist on staff with us at Sullivan. That'll help make that conversation a little bit more relatable to a significant part of the staff there.
Yeah. Well, and what you need is that, then the anesthesiologists, they can be more involved in running the PAT clinic, right? Like they can be leading those efforts. They can be involved in coordinating the care. They can even be involved in running the board, calling, helping to call the shots. Because if they're not burdened and by being stuck in an OR or even just, 2 ORs, now they're freed up to really do a lot of other things that the surgeons appreciate, the whole team of the OR can appreciate, because it's now you're helping drive everything throughout the day and you're making larger changes.
Yeah, totally agree. While we're talking about being in an OR, one of the actions that could be done to help flatten that curve, based on my observation, would be really looking at increasing your OR efficiency and your OR block utilization. How does that impact the curve of subsidies?
Yeah, I mean, greatly. And, no one is at a better position than the anesthesiologist to help on room efficiency, right? No, they're in there the longest, right? They're one of the very first ones in, they're one of the very first or last ones out, rather, the surgeons themselves don't really know much about how to make the OR more efficiently. The anesthesia providers are uniquely positioned to do that. So they're the ones who can work with and know how to work with the nurses, the techs, the rest of the staff, and will have the best ideas on room turnover, right? Like how to make those more efficient, especially the time between surgeries. As you know, those are extremely important. All that downtime is lost income, it's lost reimbursement, right? So they can be ready to help make those changes and to bring in more revenue. Really drive, like I said, helping to drive the boards, making sure the right patients are in the right locations. They can make those calls. And then also, at a more macro level, actually joining the committees. So if it's a OR governance committee or wherever they can contribute that's largely they've been locked out of, it's just the surgeons. Get your anesthesia providers in there because they know exactly how to make some improvements. They know where the opportunities are.
Yeah, that's an excellent point. And one of the things that we've kind of indicated as a lever to bend the curve would be that data transparency in a joint governance model. A great example of that is with one of my clients we're standing up. We revised their governance structure to
Mhm.
really bring their decision-making body down to 4 people, one of which is their anesthesia perioperative operations director. What we've
Right?
also done is added a second anesthesiologist as an ad hoc member. That ad hoc
Hmm.
member is going to be a member of our surgery advisory group, which is a group of 12 surgeons and proceduralists that provide advisory capacity to the executive decision making committee. That anesthesiology presence on that committee will help the communication between the executive committee as well as the advisory group, and really represent anesthesia as a practice within that group of surgeons and proceduralists. And I like to see it as a bit of a sanity check. Sometimes I think you and I both understand that, surgeons have their concept of how things should run, but it's from their perspective. And
Right?
anesthesia typically, I will say not always, but typically sees it from the perspective of the functionality of the entire operating room. And the way I've seen this in the past is, that surgeon is going to be hyper fixated, as they should be, on their patient or their patients for the day that they are taking care of, and they are successfully moving through the surgical process. The anesthesiologist, however, or especially the AIC, if you have an anesthesia in charge for the day, is not just focused on that surgeon's patients, but focused on the flow of the patients through the entire operating room for the entire day. So they see the day a little bit more broadly than your surgeons do in some situations. Incredible to have that insight from them, provided they are cooperative in the process, but that does not just apply to anesthesiologists, that applies to everybody. And it's really helpful to have that there.
Yeah. And let me just say, Stephen, you nailed it. 100% right. And this is what you just said is, in my opinion, exactly where the hospital administrators should be focused. So when they're talking about subsidy or they're complaining about they don't like it, they they should first start to partner with, approach the anesthesia providers and say, hey, how can we make things more efficient? Let's first focus on OR efficiency and let's start there. We will also have to talk about the contract. We're going to have to talk about the staffing model. We're going to have to come to a better agreement on that, right? Like we're going to have to discuss all of these things to help control that subsidy and to keep it from going up like a roller coaster that just keeps going up and never comes back down. But they need to start with exactly where you said, of inviting the anesthesia providers to the table and inviting them into the governance and start talking about the how can we make this more efficient, how can we make this better for you also as well, because at the end of the day, the anesthesia providers, especially the CRNAs, they don't like working overtime any more than anybody else, right? Like the unpredictability. And when they know that it's being run inefficiently because of something with the surgeon, you need to hear that part of the story, right? It's what you hear from the surgeon is often, well, I see the anesthesia providers sitting on their hands in there in the break room, right? Like, why isn't my OR ready? Well, there's a lot more to the story that the anesthesiology, crew can tell you, and that's where
Yeah.
you got to start.
And I'll say, I've seen a lot of those blow ups happen where it's the
Yeah.
anesthesia sitting in break room. The surgeon says, "Oh, why isn't my room ready?" And the charge
What? Yeah,
the charge
I
nurse
could
has
be
to go, "Well, why aren't the consents signed?" And it's like, "Oh, okay." It's like, let me go do that. So there's occasionally some other things impacting
yeah.
that part of the process.
Usually, and oftentimes, I'm called upon because they're starting at, well, my subsidy's going up. This is not sustainable. I can't keep paying all this money. Tim, can you all come in and look at the contract? Can you look at what they're doing? What should the staffing model be? But just as you said, Stephen, and you know this, when you get there, there's the finger pointing is going both ways. You have, anesthesia saying, well, we could probably run more efficiently and less expensively if the ORs and the surgeons were running more efficiently. Then we wouldn't have as high of subsidy because we wouldn't have the need for as many people standing in here. So that's you're exactly right, and that's where the starting point needs to be, not solely focused on how do we lower the subsidy, how can we do more with less anesthesia providers, those kinds of questions.
Yeah, and that was great that you brought up what I would consider my fifth and final point to help bend that curve, which is going to be the creative constructs within some of the anesthesia contracts that can be worked in at the time of bargaining and bringing that team on. Is there anything from your experience that really helps administrators make advantageous contracts in terms of the subsidy, or what would those sections or segments be?
Sure. So I would say, one is a real coming together on when and how do you need to use locum tenens, right? Like that's a huge expense in anesthesia,
Yeah.
and it's one that
And
it.
and just for clarity, when we say locum tenens, we're talking about like temporary like locum staff, not to be confused with the company locum tenens.
Thank you, Stephen. Yes, yeah, the actual
Yeah,
locum tenens,
I didn't want to get a nasty gram for that one, you know.
Right, good call. Yikes. We're talking about locum tenens that are, come in one at a time, two at a time from there's lots of companies out there that are providing this service. Some physicians are even doing it independently. But one of the biggest things in the contract, because that is so expensive, it's 1.5 to 1.7% of the normal salary, is coming together on agreement and alignment on when and how do you need to use a locum tenens. What's the criteria for that? The other part of it is on the contracts, really getting to clear terms on exactly what it is that you'd be paying for and what dollars get passed through directly. So in addition to locum tenens, are there other costs that really don't matter to the anesthesia group because they're just going to pass that cost right through to the hospital? And then I would say, you really want to make sure, in addition to those things, that you have visibility. The hospital administration needs to have complete transparency and visibility into the billing. Can't stress that enough. That's still being hidden. Sometimes they'll get a report, but oftentimes the billing is just being passed to the hospital to say, oops, well, we missed the target again, and we missed it by a bunch more this time. So we need more money from you. So you need the visibility into the billing. And then I would say you need visibility into the time and attendance of the actual anesthesia providers, because if it's a problem that in fact they are not spending as much time in the OR, that may not be their fault, but you still need to have visibility into that so that again you can have the discussion on what's going on here. And if it's an OR efficiency or a surgeon problem, we can address that, but you need visibility. And a lot of times the anesthesia providers just don't want to provide that. They don't want the hospital knowing that time in attendance. So I would say all of those things. Lastly, Stephen, I would say in the contract, you want language that does speak to the OR actual performance. So not just about quality, it's not just about safety. It's about that anesthesia has some skin in the game to help drive efficiency in the OR. And I know you all know all about the efficiencies, but make sure that anesthesia has some skin in the game in their contract and in whoever their medical director is, that they're helping to drive those and working alongside, to help achieve all the efforts that you are working on all the time when you're in there.
Yeah, those are great points. So we talked about like the five major factors that impact the subsidy curve. What are some indicators for hospital staff or hospital administrators or even anesthesia providers that their subsidy might need to be checked or to engage in conversations surrounding the reduction of that subsidy before it goes haywire?
That's a great question, Stephen, but I'll tell you, no one is wondering, is my subsidy out of whack? They all know my subsidy is out of control. I can't afford it. It's out of budget. But I'll tell you one of the bigger indicators, Stephen, because it is a great question. But when you're seeing the fluctuation from month to month or even quarter to quarter, that is not predictable. And this is the biggest frustration to the CFO, right? Like I can't even budget towards this because I don't know what the expense is. But when you start feeling that fluctuation that's beyond what you even budgeted for in your year, you got to really get serious really quickly because it's not going to get any better. That just means you're probably eating some costs that are just pass through costs and are not being managed, and they don't have to worry about it because you're going to eat that check.
So looking for significant variance over a short tenure would be a
Short term,
pretty
yep,
prime indicator that you have some challenges.
yeah, exactly.
Very cool. So we talked about how OR efficiency, joint governance, practical staffing ratios, creative contract constructs, and then some revenue capture optimization are really the five key ways to help control that subsidy. And we like to close these out. I like to close these out by asking what your sharpest edge is or your sharpest insight that you could bring to the table related to anesthesia subsidies or really related to anything in the healthcare realm. It's just something that we have so many intelligent, brilliant, capable, cerebral people on staff that it benefits me selfishly to say, hey, what's the smartest thing you know? What's your sharpest insight?
Wow, I love that you assume I have one, Stephen. So thank you first for that. I have something sharp to offer.
If
Um,
nothing else, it's your wit.
yeah, it's I think it's that I can, go through I can turn a 15-minute podcast into 45 minutes. So, that's that's one of my strengths.
That's called personality. You need that. As an administrator, and especially in healthcare, a little bit of personality goes a long way.
I will say, seriously that if we're speaking to the OR leadership, and I'm talking, and now I'm talking towards the non-clinical, right? I
Right.
think the thing that I can offer is to the non-clinical leadership is you've got to understand you don't have to become an anesthesia billing expert. It's nuts. I wouldn't expect you to do that. You don't have to become even, an anesthesia staffing ratio expert. It's really complicated. It can be, but you've got to understand and talk with the anesthesia providers. Don't just think of them as someone who sits on a stool behind the curtain anymore. You got to reframe your thinking about them as being someone who can really drive OR efficiency and OR profitability, and go to them and start asking them for their ideas before you start bugging them and complaining about their subsidy. At least give them the chance to help you, and not just listening to the surgeon's complaints, or the OR nurse talking, about overtime. Like, get to them and start the conversations before you need it, because you're going to have a subsidy problem. So you should start having the conversations now to see what they can do to help you.
That's a great point. And I will always champion and advocate for administrators and leaders that are non-clinical to get some clinical experience. No one's asking you to conduct surgery, but put some scrubs on, get in a room and watch what the day looks like. I did an assessment a bit ago where, we sat down with a C-suite leader who brought us in to do the assessment and gave us an entire list of his observations from the operating room. And he said, I wrote these down 15 years ago when I started here, and they're all still problems. And I was like, it's okay. So when was the last time you were in the OR and observing these
Right.
things? And he was like, oh, when I made these 15 years ago. And it's like, all right, well, maybe we see something here that we could address. So I
Yeah.
will always champion administrators putting on scrubs and really experiencing. My current client, one of them, their COO does not come from a perioperative background, but once twice a month, as his schedule allows, he'll spend a whole day in scrubs in the OR at the charge desk, circulating, looking in rooms, talking to surgeons, talking to anesthesiologists.
Yeah.
He's a new leader and he's a young
Yep.
leader in that position. But man, that is someone I would follow because he is present. I think that makes such a huge difference when it comes to impacting things in a surgical suite.
Absolutely. And, they're not looking for you to become an anesthesiologist. They're not looking for you to become the expert. They just want to know that you're listening to them and taking them into account, right? Like they have a seat at the table. I think that that's the biggest thing, is recognizing that the anesthesia providers should have a seat at the table. They're not interested anymore in just punching a time clock. They actually do want to be involved. They want to help lead.
I'll say sometimes I have a tendency not to agree with everyone just on principle, so I'll give you a sometimes on that one because in
True.
in some cases Some of them don't. They just want to go in, do anesthesia, take care of the patient, and roll out at the end of the day. And we bumped into that in the past where they'll say, I'm a doctor. I went to school to provide healthcare to patients. I have no interest in being a leader. So that's something that you have to manage as well. And that creates another unique set of circumstances to go down. But in the event, I just wanted, if you're in a facility like that where your anesthesia maybe isn't as invested in the cultural leadership of the organization, it's not completely abnormal, but it is also something to consider.
No, you're absolutely right, of course. But maybe even as a group, but you're going to have some anesthesia provider in there who is interested, who wants to do more than just pump gas. Like you'll find someone in there. And if you can't, then call me. I'll come and find them.
All right. Well, Tim, I appreciate you making it this far. I'm excited that we're on this pathway together. I'm excited for our next podcast. For those listening, if you have any questions for myself or for Tim or for anyone at Sullivan, please send us an email at podcast@sullivanhealthcareconsulting.com and we will get it. We'll respond to you. I'm pretty much glued to my email 24/7. So if it comes to me, I'll be quick with it and we'll make sure we get you to the right person to take care of you. So Tim, thanks for coming by, man, and have a good rest of your day.
Right on. You too. Thanks.